Chris,
All right.
take it away.
Last case here. This is a series of mini nightmares here. 69-year-old complex history, including, importantly, a history of aortic bifam at UVA a long time ago. She had had a right BKA, with a prosthesis that she used, lots of risk factors. She had intervention in January of 19 by one of the local vascular surgeons, and the report looked like it was revision to the left profunda limb of the aortic bifemoral graft, and he also put a nitinol stent to the distal left SFA. Unfortunately, had severe worsening, claudication at 10 feet, then progressed to critical limb ischemia, ulceration, rest pain, etc. ABI 0.18, toe pressures unobtainable, flat line. And CT angiogram, I'll show you in a moment, flush osteo-SFA occlusion, minimal reconstitution only in the perineal, aneurysmal dilatation of both common femoral arteries. Seen by the vascular surgeon, said, look, really no option. They said left BK, but probably AK, and again, she had already had a BK on the right. So happens we've merged, and she was the aunt of somebody up high in our newly merged institution, and a day and a half before I'm leaving for a meeting, they said, you know, really like a second opinion, we want to keep that leg. So here's CT angiogram. You can see the flush occlusion of the osteo-SFA. On delayed images, this is all you get is the perineal. You can see this little stent somewhere in the distal SFA, and you can see the common femoral artery aneurysmal dilatation around the prior aorta bifem. Here's a graph I did on Thursday. We were leaving Saturday morning, so first step was let's see what we got here, and this is what we got. Here's the aorta bifem. Here's a flush occlusion in the osteo-SFA. And with my foot on fluoroscopy for as long as I could take it until the room started getting warm, there's not hardly any flow getting down there, and you could barely see a remnant of the perineal if you really, really, really looked. This was a stent in that red circle somewhere in the middle of the no-flow land. So, bring back, and again, we're going to do this procedure. I'm going to ask briefly, probably one place we'll stop so we can keep on time, but panel discussions. To help me about the access here. Remember, how are we going to fix this thing? Aorta bifem graft, pretty steep bifurcation, osteoflush occlusion, minimal visible flow to even get tibial access. She's got bilateral common femoral aneurysms, and she's got some pannus to boot. So, anybody idea on access?
John, just a quick comment and then move on because I think we got very limited time.
Stick the stent.
I love you.
Go retrograde.
So I think that's exactly. There's one place I can see is that metal. So there we go. Sticking the stent, bevel up, and this is a straight glide wire through that stent going up. Now we get up there, and man, I tried a whole bunch of wires, and I can't get in that dang thing there, but finally we took the straight end of a back end of a glide wire and an angled terum, and we're able to get there. This is an 018 wire into the hood of that. Really difficult to get a wire up there, but we put a second wire to hold our place. This is an 035 angled glide wire. So now we're in good shape. We've got a sheath through the thigh all the way up here. Now we still got to fix this thing. So again, I'll just keep going for sake of time. So what we ended up doing was snaring that wire, pulling it down, externalizing it through the sheath, and then taking a navicross up and around through that. So now we've got an Ansel sheath up and around. Down here, and now we've got a wire and an Ansel all the way down through the externalized, out through the sheath and the thigh. So now we're at least getting some headway. We take this wire out, push it forward past our sheath, put a wire in here to keep that sheath from falling out halfway through while I wasn't watching, and then here we're able to cross into the perineal. There's a little lesion there, so we treated that outflow. And then really couldn't use distal protection because there's nowhere to put it. So we lasered, so 1.7 Turbo Elite, followed by 2.3 Turbo Elite, all the way down. Still no flow. So this is a 2.5 Vascutrack balloon. So we had long inflations here. And then trying to make a channel, long inflations here. And as some people know, the older Vascutrack, especially if you use it several times, won't deflate. Usually you tug on that many times, but if you have a 2.5 balloon in an SFA, you can't tug it so much. So I could not deflate that thing no matter what. So I already knew the way to her thigh. So here's a balloon, kind of got parallel to where we stuck her before. We just stuck the balloon. There it goes. So then we were able to get that thing out. And
You report this to the FDA, this balloon not deflating?
you know, we've reported enough of them in the past that they've got a new version now. On Undaunted, we used another vascular tract. This was a 300 length, but didn't inflate it. Now we've got flow. And then we IVUSed this whole thing, which was extremely helpful to how much debris, what was in lumen, not in lumen, what size, and so on. And then did some atherotomy. Now, let me ask you, so we've got, I can tell you what the IVUS showed, lots of debris. What do you think we ought to do here? Anybody? We've still got our sheath in the thigh here where this is a short stent. There's still a fair amount of debris. Any thoughts on getting the sheath out?
Sir?
I mean, this is tough. I mean, your outflow is not that great. So, I mean, you know, the choice of stent here is going to be an issue. I mean, you can repeat atherectomy and you try maybe go back with the laser or try a different type, you know, maybe a jet stream or something else to see if you can debulk it more before angioplasty. But, you know, definitely not a stent graft here, and because it's you have poor outflow. So your choices are. I think you're gonna have to debulk and keep angioplasty.
We did a little more of that, and I actually took a picture way downstream. There was 2 vessel runoff. You're going to see that in a moment. So I chose maybe an easy route, but I figured long disease with debris. I got to get the sheath out anyhow, and got it by IVUS. I did put a stent graft in there. It says 7 by 250. Figure it's good for, and that encompassed. Remember, we got a stent in there that was occluded anyhow, so I took care of that. And then I had to yank a little bit on the sheath, but now we've got a covered stent graft, so it's a nice way of hemostasis, followed by angioplasty.
Although I would say when you stick into occluded stents, you know, they usually hemostase pretty quickly and pretty easily, you know, if you just do a simple balloon inflation inside the stent.
Yeah, I think, the combination of the debris that was left and everything else. So anyhow, now, we still got a little disease down here, and I really thought that a Supera down here would not only fix this disease, but also reinforce the lack of radial strength that's sometimes present in the VIVA across the knee. So this is a long 6.0 Supera that you see here. And then, unfortunately, significant dissection here. I think an important teaching point, if we're going to fix this, this is a tibia perineal trunk. Obviously, there's your 2 vessel runoff sire. So really, there's not a drug-eluting stent that's long enough for this nor big enough for that. And I don't like that much metal stent in the pop anyhow. If you're going to put some drug-eluting stent in the TP trunk and a Supera, I think it's important to do it in the right order. So if you put the Supera in first and then add it, you're safe. If you put the drug-eluting stent and then the Supera, that nose cone will go into that drug-eluting stent and distort it. So you don't want to do that. So this is a Supera here and then a Xience here. And then finally a Zilver PTX. We thought we were right there perfectly on the roadmap, but it missed the ostium. Remember, I had a heck of a time getting that open to begin with. So we did DCB that ostium. And at the end of our adventures, here's the SFA. And there's a 2 vessel runoff sire, and it actually picked up the dorsalis pedal artery very nicely. So a little bit of a series of events, and more than a nightmare was, gosh, I got to do this on Friday before I leave for a meeting with a full case already. But I think at least a nice things that you can think about for access that are unique.
Great. Wow. A remarkable case, and no surprise, it's a great case to finish with, to finish VIVA with. It sort of shows the innovative spirit and tenacity and watching out for complications and trying to do the best you can for the patient. It sort of sums up all of VIVA, Chris. Thank you very much. So with that, I'm going to hand the